Hypocalcemia. Hypocalcemia, low serum calcium, can result from any condition associated with PTH deficiency. This may occur with surgical removal of, part of, or injury to the parathyroid glands during thyroid or neck surgery, or with neck radiation. The patient who receives multiple blood transfusions can develop hypocalcemia because citrate, used as an anticoagulant in blood bags, binds with calcium, decreasing ionized calcium levels. Sudden alkalosis may result in symptomatic hypocalcemia despite a normal total serum calcium level. The high pH increases calcium binding to protein, decreasing the amount of ionized calcium. Table 16.8 lists causes and manifestations of hypocalcemia. Low ionized calcium levels decrease the threshold for activating the sodium channels that cause cell membrane depolarization. This results in increased nerve excitability and sustained muscle contraction, or tetany. Clinical signs of tetany include Chvostek's sign and Trousseau's sign. Chvostek's sign is contraction of facial muscles in response to a tap over the facial nerve in front of the ear, figure 16.15a. Trousseau's sign refers to carpal spasms induced by inflating a BP cuff on the arm, figure 16.15b and c. When you inflate the cuff above the systolic pressure, carpal spasms occur within 3 minutes if hypocalcemia is present. Other manifestations of tetany are laryngeal stridor, dysphagia, paresthesia, and numbness and tingling around the mouth or in the extremities. Cardiac effects include decreased cardiac contractility and ECG changes. A prolonged QT interval may develop into ventricular tachycardia. Nursing and interprofessional management. Hypocalcemia. Nursing diagnoses. Nursing diagnoses and collaborative problems for the patient with hypocalcemia include electrolyte imbalance, impaired breathing, activity intolerance, potential complications, fracture, respiratory arrest. Managing hypocalcemia depends on the underlying cause and the presence of symptoms. Treating mild or asymptomatic hypocalcemia involves a diet high in calcium-rich foods and calcium and vitamin D supplementation. Symptomatic hypocalcemia is treated with IV calcium gluconate. Measures to promote CO2 retention, such as breathing into a paper bag or sedating the patient, can control the muscle spasm and other symptoms of tetany until the calcium level is corrected. Patients taking loop diuretics may need to change to thiazide diuretics to decrease urinary calcium excretion. Closely assess any patient who had thyroid or neck surgery in the immediate postoperative period for manifestations of hypocalcemia because of the proximity of the surgery to the parathyroid glands. Adequately treat pain and anxiety because hyperventilation-induced respiratory alkalosis can precipitate hypocalcemic symptoms. Phosphate imbalances. Phosphorus is the primary anion in ICF and the second most abundant element in the body after calcium. Most phosphorus is in bones and teeth as calcium phosphate. The remaining phosphorus is metabolically active in the form of phosphate salts. Thus, we use the terms phosphorus and phosphate interchangeably in this text. Phosphate is essential to the function of muscle, red blood cells, and the nervous system. It is involved in the acid-base buffering system, the mitochondrial formation of ATP, cellular uptake and use of glucose, and carbohydrate, protein, and fat metabolism. PTH maintains serum phosphate levels in balance. Proper phosphate balance requires adequate renal functioning because the kidneys are the major route of phosphate excretion. When the phosphate level in the glomerular filtrate falls below normal or PTH levels are low, the kidneys reabsorb more phosphate. A reciprocal relationship exists between phosphate and calcium. This means a low serum calcium level will result in a high phosphate level and vice versa. Hyperphosphatemia. Hyperphosphatemia, high serum phosphate, is common in patients with acute kidney injury or chronic kidney disease, which alter the kidney's ability to excrete phosphate. Other causes include excess phosphate intake from the use of phosphate-containing laxatives or enemas, or a shift of phosphate from ICF to ECF. This may occur in patients with tumor lysis syndrome or rhabdomyolysis. Hypoparathyroidism and vitamin D intoxication cause increased kidney phosphate reabsorption. Table 16.9 describes causes and manifestations of hyperphosphatemia. Hyperphosphatemia can be asymptomatic unless calcium binds with phosphate, leading to manifestations of hypocalcemia. These include tetany, muscle cramps, paresthesias, hypotension, dysrhythmias, and seizures. Long-term, increased phosphate levels result in the development of calcified deposits outside of the bones. These calcium deposits can be found in soft tissues such as joints, arteries, skin, corneas, and kidneys, and cause organ dysfunction, notably renal failure. Managing hyperphosphatemia involves identifying and treating the underlying cause, restrict the intake of foods and fluids high in phosphorus, e.g. dairy products. Oral phosphate-binding agents, e.g. calcium carbonate, limit intestinal phosphate absorption and increase phosphate secretion in the intestine. With severe hyperphosphatemia, hemodialysis may be used to rapidly decrease levels. Volume expansion and forced diuresis with a loop diuretic may increase phosphate excretion. If hypocalcemia is present, institute measures to correct calcium levels. See Chapter 46 for more information about treating hyperphosphatemia associated with kidney disease. Hypophosphatemia. Hypophosphatemia, low serum phosphate, can result from decreased intestinal absorption, increased urinary excretion, or ECF to ICF shifts. Malabsorption, diarrhea, and phosphate-binding antacids lead to decreased absorption. Phosphate shifts occur in respiratory alkalosis, treatment of diabetic ketoacidosis, and refeeding syndrome, reinstitution of nutrition to patients who are severely malnourished. Hypophosphatemia may occur in those who are malnourished or receive parenteral nutrition with inadequate phosphorus replacement. Table 16.9 lists causes and manifestations of hypophosphatemia. Most of the manifestations of hypophosphatemia result from impaired cellular energy and O2 delivery due to low levels of cellular ATP and 2 and 3 diphosphoglycerate, 2,3-DPG, an enzyme in RBCs that facilitates O2 delivery to the tissues. Mild to moderate hypophosphatemia is often asymptomatic. Severe hypophosphatemia may be fatal because of decreased cellular function. Acute manifestations include CNS depression, muscle weakness and pain, respiratory failure, and heart failure. Chronic hypophosphatemia alters bone metabolism, resulting in rickets and osteomalacia. Managing mild phosphate deficiency involves increasing oral intake with dairy products or phosphate supplements. Dairy products are better tolerated because phosphate supplements are often associated with adverse GI effects, including diarrhea and bloating. Symptomatic hypophosphatemia can be fatal and usually requires IV administration of sodium phosphate or potassium phosphate. During IV replacement, monitor serum calcium and phosphate levels every 6 to 12 hours. Perform frequent assessment during IV therapy, as complications include hypocalcemia, hyperkalemia, hypotension, and dysrhythmias. Magnesium imbalances. Magnesium, the second most abundant intercellular cation, plays a key role in essential cellular processes. It is a cofactor in many enzyme systems, including those responsible for carbohydrate metabolism, DNA and protein synthesis, blood glucose control, and BP regulation. Magnesium is needed for the production and use of ATP, the energy source for the sodium-potassium pump. Muscle contraction and relaxation, normal neurologic function, and neurotransmitter release depend on magnesium. About 50% to 60% of the body's magnesium is stored in muscle and bone. 30% is in cells, with only 1% in ECF. The kidneys and GI system regulate serum magnesium by controlling the amount of magnesium reabsorbed in the ascending loop of Henle and distal tubules and absorption in the small intestine. GI absorption and renal reabsorption increase when magnesium levels are low. Hypermagnesemia. Hypermagnesemia, high serum magnesium level, usually occurs only with increased magnesium intake accompanied by renal insufficiency or failure. A patient with chronic kidney disease who ingests products containing magnesium, e.g. Malox or milk of magnesia, will have a problem with excess magnesium. Magnesium excess could develop in a pregnant woman receiving magnesium sulfate for the treatment of eclampsia, or in patients taking laxatives and antacids that contain magnesium. Table 16.10 lists the causes and manifestations of hypermagnesemia. Excess magnesium inhibits acetylcholine release at the myoneural junction and calcium movement into cells, impairing nerve and muscle function. Initial manifestations include hypotension, facial flushing, lethargy, urinary retention, nausea, and vomiting. As the serum magnesium level increases, deep tendon reflexes are lost, followed by muscle paralysis and coma. Respiratory and cardiac arrest can occur. Management begins with avoiding magnesium-containing drugs and limiting dietary intake of magnesium-containing foods, e.g. green vegetables, nuts, bananas, oranges, peanut butter, chocolate. If renal function is adequate, increased fluids and diuretics promote urinary excretion of magnesium. The patient with impaired renal function may need dialysis. If hypermagnesemia is symptomatic, giving IV calcium gluconate will oppose the effects of the excess magnesium on cardiac muscle. Hypomagnesemia. Hypomagnesemia, low serum magnesium level, occurs in patients with limited magnesium intake or increased GI or renal losses. Causes of hypomagnesemia from insufficient food intake include prolonged fasting or starvation and chronic alcohol use. Another potential cause is prolonged parenteral nutrition without magnesium supplementation. Fluid loss from the GI tract, acute pancreatitis, and poorly controlled diabetes may contribute to hypomagnesemia. Diuretics, proton pump inhibitors, and certain antibiotics may lead to magnesium loss. Table 16.10 lists the causes and manifestations of hypomagnesemia. Clinically, hypomagnesemia resembles hypocalcemia. Neuromuscular manifestations are common, such as muscle cramps, tremors, hyperactive deep tendon reflexes, Chvostek's sign, and Trousseau's sign. Neurologic manifestations include confusion, vertigo, and seizures. Dysrhythmias, such as torsades de pointe and ventricular fibrillation, can occur. Management depends on the underlying cause and the patient's symptoms. Mild magnesium deficiency involves oral supplements and increased dietary intake of foods high in magnesium. If the deficiency is severe, or if hypocalcemia is present, IV magnesium, e.g. magnesium sulfate, is given. Monitor vital signs and use an infusion pump, since rapid administration can lead to hypotension and cardiac or respiratory arrest. Acid-base imbalances. The The body normally maintains a steady balance between the acids continuously produced during normal metabolism and the bases that neutralize and promote the excretion of the acids. Because these acids alter the body's internal environment, their regulation is necessary to maintain homeostasis and acid-base balance. Many health problems may lead to acid-base imbalances. Patients with diabetes, chronic obstructive pulmonary disease, COPD, and kidney disease often develop acid-base imbalances. Remember that an acid-base imbalance is not a disease but a symptom of an underlying health problem. Always consider the possibility of acid-base imbalance in patients with serious illnesses. pH and hydrogen ion concentration. The acidity or alkalinity of a solution depends on its hydrogen ion H+ concentration. An increase in H+ concentration leads to acidity. A decrease leads to alkalinity. H+ concentration is usually expressed as a negative logarithm, symbolized as pH. The use of the negative logarithm means that the lower the pH, the higher is the H+ concentration. The pH of a chemical solution may range from 1 to 14. A solution with a pH of 7 is considered neutral. An acid solution has a pH less than 7, and an alkaline solution has a pH greater than 7. Blood is slightly alkaline and has a normal arterial pH of 7.35 to 7.45. Medically, if the pH drops below 7.35, a person has acidosis. If the blood pH is greater than 7.45, the person has alkalosis. Figure 16.16. Acid-base regulation. The body uses three mechanisms to regulate acid-base balance and keep the pH between 7.35 and 7.45. These are the buffer systems, respiratory system, and renal system. Each mechanism reacts at different speeds. Buffers are the fastest, reacting immediately. The respiratory system responds in minutes and reaches maximum effectiveness in hours. The renal response occurs hours to days after a change in pH. The kidneys can maintain balance indefinitely in patients with chronic imbalances. But if the person has impaired kidney function, the kidneys will not be effective in maintaining acid-base balance. Buffer system. Buffering is the primary regulator of acid-base balance. Buffers act chemically to change strong acids into weaker ones or bind acids to neutralize them. This minimizes the effect of acids on blood pH until they can be excreted from the body. Buffers can maintain pH only if the respiratory and renal systems function adequately. All body fluids contain buffers. The major buffer in ECF is the carbonic acid bicarbonate system, H2CO3/HCO3 negative. Other buffer systems include phosphate, protein, and hemoglobin. The cell can act as a buffer by shifting H+ in and out of the cell. When ECF levels of H+ are increased, H+ enters the cell in exchange for potassium. This may result in hyperkalemia as potassium moves into the ECF. Conversely, with decreased H+ levels, H+ enters plasma in exchange for potassium. This is why a patient with alkalosis can develop hypokalemia. A buffer consists of a weak acid, which releases H+ when fluid is too alkaline, or a base and its salt, which takes up H+ when fluid is too acidic. The carbonic acid bicarbonate buffer system neutralizes hydrochloric acid, HCl, a strong acid, by combining it with a strong base. This prevents the acid from making a large decrease in pH. The carbonic acid is broken down into H2O and CO2. The lungs excrete CO2, either combined with insensible H2O as carbonic acid or alone as CO2. The phosphate, protein, and hemoglobin buffer systems act in the same way as the bicarbonate system. The main components of the phosphate system are monohydrogen phosphate, HPO42 negative, and dihydrogen phosphate, H2PO4 negative. A phosphate combined with sodium can neutralize a strong acid, such as HCl, by forming sodium chloride, NaCl, and sodium biphosphate, NaH2PO4, a weak acid. If a strong base, such as sodium hydroxide, NaOH, is present, sodium biphosphate, NaH2PO4, neutralizes it to a weaker base, Na2HPO4, and H2O. Intracellular and extracellular proteins can act as an acid or base. Because the chemical structure of amino acids has an acid and a base, they can accept H+ if pH decreases or release H+ if fluid is too alkaline. Some amino acids have basic radicals, NH3OH, ammonium hydroxide, that can dissociate into NH3 plus ammonia and OH negative hydroxide. The OH negative can combine with H+ to form H2O. Hemoglobin can bind with both H+, forming a weak acid, and CO2, forming carbaminohemoglobin, HbCO2. HbCO2 dissociates in the lungs, releasing CO2 for exhalation. Because H+ can combine only with hemoglobin that has released its O2, venous blood is a better buffer than arterial blood, which contains saturated hemoglobin. Hemoglobin also aids in controlling pH by shifting chloride in and out of RBCs in exchange for bicarbonate. The buffer system maintains a 20-to-1 ratio between HCO3 negative and carbonic acid in ECF. The body's ability to keep this ratio is important in controlling pH. For example, excess carbonic acid increases the ratio and decreases pH, resulting in acidosis. In response, the body can increase HCO3 negative levels to keep the ratio 20-to-1 and keep the pH near normal, a state called compensation. For example, a ratio of 40-to-2 is present in compensated acid-base balance. Respiratory system. The lungs help maintain a normal pH by excreting CO2 and water, which are byproducts of cellular metabolism. When released into the circulation, CO2 enters RBCs and combines with H2O to form H2CO3. Carbonic acid dissociates into H+ and HCO3 negative. Hemoglobin buffers the free H+ and the HCO3 negative diffuses into the plasma. This process is reversed in the pulmonary capillaries, forming CO2 that is excreted by the lungs. The amount of CO2 in the blood directly relates to carbonic acid and H+ concentration. With increased respirations, more CO2 is expelled and less stays in the blood. This leads to less carbonic acid and less H+. With decreased respirations, more CO2 stays in the blood. This leads to increased carbonic acid and more H+. The respiratory center in the medulla controls the rate of excretion of CO2. If increased amounts of CO2 or H+ are present, the respiratory center stimulates an increased rate and depth of breathing to blow off CO2 through hyperventilation. If the center senses low H+ or CO2 levels, respirations are reduced and CO2 retained. The older adult has an impaired compensatory ability due to decreased respiratory function. Renal system. Under normal conditions, the body depends on the kidneys to reabsorb and conserve all the HCO3 negative they filter and excrete some of the acid produced by cellular metabolism. The three mechanisms of acid excretion include 1. Secreting small amounts of free hydrogen into the renal tubule, 2. Combining H+ with ammonia, NH3, to form ammonium, NH4+, and 3. Excreting weak acids. The kidneys normally excrete acidic urine. Average pH is 6. As a compensatory mechanism, The pH of the urine can decrease to 4 or increase to 8. To compensate for acidosis, the kidneys can reabsorb more HCO3 negative and excrete excess H+. This increases the blood pH and decreases the urine pH. In the older adult, the kidneys are less able to compensate for acid load. Alterations in acid-base balance. An acid-base imbalance results when there is a change in the ratio of 20:1 between base and acid content. This occurs when a disease or process alters one side of the ratio, e.g. CO2 retention in pulmonary disease, and the compensatory processes that maintain the other side of the ratio, e.g. increased renal HCO3 negative reabsorption, either fail or are inadequate. The compensatory process may be inadequate because either the pathophysiologic activity is overwhelming or there is not enough time for the compensatory process to work. Acid-base imbalances are classified as respiratory or metabolic. Respiratory imbalances result from changes in carbonic acid concentration. Metabolic imbalances affect the base HCO3 negative. Acidosis occurs when an increase in carbonic acid, respiratory acidosis, or decrease in HCO3 negative, metabolic acidosis. Alkalosis occurs with a decrease in carbonic acid, respiratory alkalosis, or increase in HCO3 negative, metabolic acidosis. Imbalances are further classified as acute or chronic. Chronic imbalances allow greater time for compensatory changes. Respiratory acidosis. Respiratory acidosis, carbonic acid excess, occurs when a person has hypoventilation, table 16.11. Hypoventilation leads to a buildup of CO2, resulting in an accumulation of carbonic acid in the blood. Carbonic acid dissociates, releasing H+ and decreasing pH. If CO2 is not eliminated from the blood, acidosis results from the accumulation of carbonic acid. Figure 16.17a. During acute respiratory acidosis, the renal compensatory mechanisms begin to work within 24 hours. The kidneys conserve HCO3 negative and secrete increased H+ into the urine. Until the renal mechanisms have an effect, the serum HCO3 negative level will usually be normal and then increase. Respiratory alkalosis. Respiratory alkalosis, carbonic acid deficit, occurs with hyperventilation, or an increase in respiratory rate or volume, table 16.11. The primary cause of respiratory alkalosis is hypoxemia from acute pulmonary disorders, e.g. pneumonia, pulmonary embolus. Hyperventilation can occur as a physiologic response to metabolic acidosis and increased metabolic demands, e.g. fever. Pain, anxiety, and some CNS disorders can increase respirations without a physiologic need. The decrease in the arterial CO2 level leads to decreased carbonic acid concentration in the blood and an increased pH. Figure 16.17a. Compensated respiratory alkalosis is rare. In acute respiratory alkalosis, aggressive treatment of the cause of hypoxemia is essential and usually does not allow time for compensation to occur. If the respiratory alkalosis is caused by significant pain, anxiety, or panic, breathing into a closed system to rebreathe eliminated CO2 can aid in the compensatory process. Some buffering may occur with shifting of HCO3 negative into cells in exchange for chloride ions, Cl negative. In chronic respiratory alkalosis that occurs with pulmonary fibrosis or CNS disorders, compensation may include renal excretion of HCO3 negative. Metabolic acidosis. Metabolic acidosis, base bicarbonate deficit, occurs when an acid other than carbonic acid accumulates in the body, or when bicarbonate is lost in body fluids, table 16.11 and figure 16.17b. Keto acid accumulation in diabetic ketoacidosis and lactic acid accumulation with shock are examples of acid accumulation. Severe diarrhea resulting in loss of HCO3 negative is an example of base deficit. In renal disease, the kidneys lose their ability to reabsorb HCO3 negative and secrete H+. To compensate for metabolic acidosis, the kidneys try to excrete extra acid and the lungs increase CO2 excretion. The patient often develops Kussmaul respirations, deep, rapid breathing, when trying to compensate for metabolic acidosis. If metabolic acidosis is present, calculating the anion gap helps determine the source of the acidosis. The anion gap is the difference between the measured serum cations and anions in ECF. Metabolic alkalosis. Metabolic alkalosis, base bicarbonate excess, occurs when a loss of acid, e.g. from prolonged vomiting or gastric suction, or a gain in HCO3 negative, e.g. from ingestion of baking soda, occurs. Table 16.11 and Figure 16.17b. Renal excretion of HCO3 negative occurs in response to metabolic alkalosis. The lung's compensatory response is limited. The respiratory rate decreases to retain plasma CO2. However, once hypoxemia occurs or plasma CO2 reaches a certain level, stimulation of chemoreceptors will increase respirations. Mixed acid-base disorders. A mixed acid-base disorder occurs when two or more disorders are present at the same time. The pH depends on the type, severity, and acuity of each disorder involved and any compensatory mechanisms at work. Respiratory acidosis combined with metabolic alkalosis, e.g. a patient with atelectasis and NG suction, may result in a near normal pH. Respiratory acidosis combined with metabolic acidosis causes a greater decrease in pH than either disorder alone. An example of a mixed acidosis is a patient in severe shock with poor perfusion and hypoventilation. Mixed alkalosis can occur in a patient hyperventilating because of postoperative pain who is losing acid from NG suctioning. Clinical manifestations of acid-base imbalances. The manifestations of acidosis and alkalosis are outlined in Tables 16.12 and 16.13. In both respiratory and metabolic acidosis, the CNS is depressed. Headache, lethargy, weakness, and confusion develop, leading eventually to coma and death. Compensatory mechanisms also produce specific manifestations. For example, the deep, rapid Kussmaul respirations of a patient with metabolic acidosis occur with respiratory compensation. In both types of alkalosis, symptoms usually result from an accompanying electrolyte abnormality rather than the alkalosis. Hypocalcemia occurs due to increased calcium binding with albumin, lowering the amount of ionized active calcium. Therefore, muscle cramping and symptoms of CNS excitability, including tingling and numbness of the fingers and tetany, occur. If left untreated, respiratory alkalosis can be life-threatening. Blood gas values. Arterial blood gas, ABG, values give objective information about a patient's acid-base status, the underlying cause of an imbalance, and the body's ability to regulate pH. Knowing the patient's clinical situation and the extent of renal and respiratory compensation allows you to identify acid-base disorders and the patient's ability to compensate. Blood gas analysis also shows the partial pressure of arterial O2, PaO2, and O2 saturation. Table 16.14 lists normal blood gas values. These values help you evaluate the patient's overall oxygenation status and identify hypoxemia. Table 16.5 shows ROME, a quick memory device for understanding acid-base imbalances. To interpret the results of an ABG, perform the following 5 steps. 1. Look at each of the values. If the pH is between 7.35 and 7.45, and the CO2, HCO3 negative, and PaO2 are within normal limits, the ABGs are normal. If any value is out of normal, then continue. 2. Look at the pH first. Values less than 7.35 indicate acidosis, and values greater than 7.45 indicate alkalosis. A normal pH means there is normal acid-base status. Compensation is occurring or a mixed disorder is present. Use Rome, table 16.15, to figure out if the origin is respiratory or metabolic. Remember, respiratory opposite and metabolic equal. 4. Once the metabolic or respiratory origin is determined, look at the remaining value, either the CO2 or HCO3 negative, to figure the level of compensation. If the value is moving in the opposite direction, the body is trying to compensate. If the remaining value moving to compensate is abnormal, and the pH is higher or lower than normal, partial compensation has occurred. If the pH is within normal limits, full compensation has occurred. 5. Assess the PaO2 and O2 saturation. If these values are abnormal, hypoxemia is present. Table 16.16 explains how to analyze ABG results. The laboratory findings section of Table 16.11 shows ABG findings of the 4 major acid-base imbalances. See Chapter 25 for further discussion of ABGs. Assessment of fluid, electrolyte, and acid-base imbalances. Assessing patients for fluid, electrolyte, and acid-base imbalances is an important part of your nursing practice. In addition to assessing for the manifestations discussed earlier in this chapter, obtain subjective and objective data from any patient with suspected fluid, electrolyte, or acid-base imbalances. Subjective data. Important health information. Past health history. Question the patient about any history of problems involving the kidneys, heart, GI system, or lungs that could affect the present fluid, electrolyte, and acid-base balance. Ask about specific diseases such as diabetes, diabetes insipidus, COPD, renal failure, ulcerative colitis, and Crohn's disease. Assess for any prior fluid, electrolyte, or acid-base disorders. Medications. Assess the patient's current and past use of medications. The ingredients in many drugs, especially over-the-counter drugs, are often hidden sources of sodium, potassium, calcium, magnesium, and other electrolytes. Many prescription drugs, including diuretics, corticosteroids, and electrolyte supplements, can cause fluid and electrolyte imbalances. Surgery or other treatments. Ask the patient about past or present renal dialysis, kidney surgery, or bowel surgery, resulting in a temporary or permanent external collecting system, such as an ileostomy. Functional health patterns. Health perception, health management pattern. If the patient currently has a problem related to fluid, electrolyte, and acid-base balance, obtain a careful description of the illness, including onset, course, and treatment. Ask the patient about any recent changes in body weight. Nutritional, metabolic pattern. Ask the patient about diet and any special dietary practices, weight reduction diets, fad diets, or any eating disorders such as anorexia or bulimia can lead to fluid and electrolyte problems. If the patient is on a special diet such as low sodium or high potassium, assess the ability to adhere to the dietary prescription. Elimination pattern. Make note of the patient's usual bowel and bladder habits. Carefully document any deviations from the expected elimination pattern, such as diarrhea, oliguria, polyuria, or incontinence. Activity exercise pattern. Ask about the patient's exercise pattern and any excess perspiration. Determine if the patient is exposed to extremely high temperatures during leisure or work activity. Ask the patient what he or she does to replace fluid and electrolytes lost through excess perspiration. Assess the patient's activity level to determine any functional problems that could lead to lack of ability to obtain food or fluids. Cognitive perceptual pattern. Ask about any changes in sensations such as numbness, tingling, or muscle weakness, which could indicate a fluid and electrolyte problem. Ask the patient and caregiver if there have been any changes in mentation or alertness, such as confusion, memory impairment, or lethargy. Objective data. Physical examination. Perform a complete physical examination because fluid, electrolyte, and acid-base balance affects all body systems. As you assess each system, check for manifestations that you would expect with an imbalance. Common abnormal assessment findings of major body systems offer clues to possible imbalances, Table 16.17. Laboratory values. Assessing serum electrolyte values is a good starting point for evaluating fluid and electrolyte balance, Table 16.1. Serum electrolytes can also provide important information about a patient's acid-base balance. Changes in the serum HCO3 negative, often reported as total CO2 or CO2 content on an electrolyte panel, indicate metabolic acidosis. low HCO3 negative level, or alkalosis, high HCO3 negative level. Remember that serum electrolyte values often provide limited information. They reflect the concentration of that electrolyte in ECF, but not necessarily in ICF. For example, most potassium is found in the cells. Changes in serum potassium values may be the result of a true deficit or excess of potassium, or reflect the movement of potassium into or out of the cell during acid-base imbalances. An abnormal serum sodium level may reflect a sodium problem or, more likely, a water problem. Other useful laboratory tests include serum and urine osmolality, serum glucose, blood urea nitrogen, serum creatinine, venous blood gas sampling, urine-specific gravity, and urine electrolytes. Oral fluid and electrolyte replacement. In all cases of fluid, electrolyte, and acid-base imbalances, the primary treatment involves correcting the underlying cause. Oral rehydration solutions containing water, potassium, sodium, and glucose may be used to correct mild fluid and electrolyte deficits. Glucose not only provides calories, but also promotes sodium and water absorption in the small intestine. Commercial oral rehydration solutions are now available for home use. Avoid cola drinks because they do not contain adequate electrolyte replacement, and the sugar content may lead to osmotic diuresis. IV fluid and electrolyte replacement. IV fluid and electrolyte therapy are necessary to treat many different fluid and electrolyte imbalances. Many patients need maintenance IV fluid therapy when they cannot take oral fluids, e.g. during and after surgery. Other patients need corrective or replacement therapy for losses that are ongoing or have already occurred. The amount and type of solution is determined by the normal daily maintenance requirements and by imbalances identified by laboratory results. We classify IV replacement solutions by their concentration, or tonicity, table 16.18. Tonicity is a key factor in determining the appropriate solution to correct imbalances. Solutions. Hypotonic. A hypotonic solution has a lower osmolality when compared to plasma. Infusing a hypotonic solution dilutes ECF, lowering serum osmolality. Osmosis then produces a movement of water from ECF to interstitial spaces in cells, causing cells to swell. After achieving equilibrium, ICF and ECF have the same osmolality. Hypotonic solutions, e.g. 0.45% sodium chloride, are useful in treating patients with hypernatremia. They are good maintenance fluid because normal daily losses are hypotonic. They are not good for replacement because they can deplete ECF and lower BP. Because hypotonic solutions have the potential to cause cellular swelling, monitor patients for changes in mentation that may indicate cerebral edema. Although 5% dextrose in water is technically an isotonic solution, the dextrose quickly metabolizes. The net result is the administration of hypotonic-free water with equal expansion of ECF and ICF. 1 liter of a 5% dextrose solution provides 50 grams of dextrose, or 170 calories. While this amount of dextrose is not enough to meet caloric requirements, it helps prevent ketosis associated with starvation. Isotonic. An isotonic solution has an osmolality similar to plasma. Because of this similarity, giving an isotonic solution expands only ECF, and the fluid does not move into cells. This makes isotonic solutions the ideal fluid replacement for patients with ECF volume deficits. Examples of isotonic solutions include 0.9 sodium chloride and lactated ringer solution. Isotonic saline, 0.9% sodium chloride, or normal saline, has a sodium concentration, 154 millicues per liter, slightly higher than that of plasma, 135 to 145 millicues per liter, and a chloride concentration, 154 millicues per liter, significantly higher than the plasma chloride level, 96 to 106 millicues per liter. Therefore, giving too much isotonic saline has the potential to increase sodium and chloride levels. Isotonic saline is used when a patient has had both fluid and sodium losses, e.g. diarrhea, vomiting. Lactated ringer solution contains sodium, potassium, chloride, calcium, and lactate, the precursor of bicarbonate, in about the same concentrations as ECF. This makes it the ideal fluid in certain situations, such as surgery, burns, or GI fluid losses. Patients with liver dysfunction, hyperkalemia, and severe hypovolemia should not receive lactated ringers because they have a decreased ability to convert the lactate to bicarbonate. Hypertonic. A hypertonic solution has a higher osmolality than plasma. The higher osmotic pressure draws water out of the cells into ECF. It is useful in the treatment of hyponatremia and trauma patients with head injury. Those receiving hypertonic solutions need frequent monitoring of BP, lung sounds, and serum sodium levels because of the risk for intravascular fluid volume excess. Although concentrated dextrose and water solutions, 10% dextrose or greater, are hypertonic solutions, once the dextrose is metabolized, the net result is the administration of water. This free water ultimately expands ECF and ICF. The primary use of these solutions is providing calories as part of parenteral nutrition. See Chapter 39. You may give solutions containing 10% dextrose or less through a peripheral line. You must use a central line to give solutions with dextrose concentrations greater than 10%. IV additives. Additives in basic IV solutions replace specific losses. KCl, CaCl2, MgSO4, and HCO3 negative are common additives. The use of each was described earlier in the discussion of the specific electrolyte deficiencies. Many premixed IV solutions containing specific additives are available. Using these solutions reduces error, as the solution contains the correct amount of the electrolyte in the proper volume and type of IV solution. Colloids. Colloid solutions contain large molecules that increase oncotic pressure and pull fluid into the blood vessels. Because this action restores blood volume, colloids are often called volume expanders or plasma expanders. Colloids include human plasma products, albumin, fresh frozen plasma, blood, and semi-synthetic solutions, dextran, starches. Albumin is available in 5% and 25% solutions. The 5% solution has an albumin concentration similar to that of plasma and results in plasma volume expansion equal to the volume infused. This makes it ideal for treating hypovolemic patients. In contrast, 25% albumin solution is hypertonic and draws fluid from the interstitial space. This makes it useful in treating patients with burns, hepatic failure, and ascites. Dextran solutions are synthetic complex sugar solutions. There are two types: low molecular weight dextran, dextran 40, and high molecular weight dextran, dextran 70. Because dextran metabolizes slowly, it stays in the vascular system for a prolonged period. It pulls fluid into the intravascular space, expanding it by more volume than what is infused. Hydroxyethyl starches, e.g. Hespan, are synthetic colloids that work similarly to dextran to expand plasma volume. Colloids can lead to circulatory overload because they pull fluid into ECF. Monitor vital signs and urine output frequently and assess for signs and symptoms of fluid volume excess. All colloids affect blood coagulation, with dextran and starches having the strongest anticoagulation effect. Monitor coagulation times and implement any necessary precautions. Fatal anaphylactic reactions have occurred with Hespan and dextran. Monitor the patient closely for a hypersensitivity reaction and stop an infusion at once if a reaction occurs. If the patient has lost blood, whole blood or packed RBCs are given. Packed RBCs have the advantage of giving the patient primarily RBCs rather than RBCs and fluid volume. Although packed RBCs have a decreased plasma volume, they increase the oncotic pressure and pull fluid into the intravascular space. The use of whole blood with its added fluid volume may cause circulatory overload, particularly in patients who are susceptible to complications from excess circulating fluid, e.g. heart failure. To prevent fluid volume excess, loop diuretics may be given with blood and colloids. See Chapter 30 for more information on giving blood and blood products. Central venous access devices. Central venous access devices, CVADs, are catheters placed in large blood vessels, e.g. subclavian vein, jugular vein, of people who need frequent or special access to the vascular system. There are three main types of CVADs: centrally inserted catheters, peripherally inserted central catheters, PICCs, and implanted ports. Advantages of CVADs include immediate access to the central venous system, a reduced need for multiple venipunctures, and decreased risk for extravasation injury. CVADs permit frequent, continuous, rapid, or intermittent administration of fluids and medications. They allow for the administration of drugs that are potential vesicants, agents that can cause tissue damage, blood and blood products, and parenteral nutrition. CVADs can provide a means to perform hemodynamic monitoring and obtain venous blood samples. They are useful with patients who have limited peripheral vascular access or who have a projected need for long-term vascular access. CVADs also can be used to inject radiopaque contrast media. Table 16.19 gives examples of when CVADs are used. The major disadvantages of CVADs are an increased risk for systemic infection and the invasiveness of the procedure. Extravasation, leakage of fluid, can still occur if there is a displacement of or damage to the device. Centrally inserted catheters. The tip of centrally inserted catheters, also called central venous catheters, CVCs, rests in the distal end of the superior vena cava near its junction with the right atrium, figure 16.18. The other end of the catheter exits through a separate incision on the chest or abdominal wall. Non-tunneled catheters are usually placed in the subclavian or internal jugular vein, more rarely in the femoral vein. They are best for patients with short-term needs in an acute care setting. Surgically placed tunneled catheters, e.g. Hickman, Broviac, Grosshong, are suitable for long-term needs. Tunneling of the catheter through subcutaneous tissue and the synthetic cuff used to anchor the catheter provides stability and decrease infection risk. After the site heals, the catheter does not need a dressing, making it easier for the patient to maintain the site at home. CVCs are available with single, double, or triple lumens. Multi-lumen catheters are useful in the critically ill patient because each lumen can be used simultaneously to provide a different therapy. For example, incompatible drugs infuse in separate lumens without mixing, while a third lumen gives access for blood sampling. Peripherally inserted central catheters. Peripherally inserted central catheters, PICCs, are CVCs inserted into a vein in the arm. The basilic vein is best because of its large diameter, figure 16.19. The cephalic, median cubital, or brachial veins are other options. Single, double, or triple lumens are available. Double lumens are preferred because they allow for simultaneous uses. PICCs are used with patients who need vascular access for 1 week to 6 months, but they can be in place for longer periods. Advantages of a PICC over a CVC are lower infection rates, fewer insertion-related complications, decreased cost, and ability to insert at the bedside or in an outpatient area. PICCs, however, are associated with an increased risk for deep vein thrombosis and phlebitis, table 16.20. If phlebitis occurs, it usually happens within 7 to 10 days after insertion. Do not use the arm with the PICC to take a BP reading or draw blood. When the BP cuff is inflated, the PICC can touch the vein wall, increasing the risk for vein damage and thrombosis. Implanted infusion ports. An implanted infusion port consists of a surgically implanted CVC connected to a reservoir or port, figure 16.20a. The catheter tip lies in the desired vein. The port lies in a surgically created subcutaneous pocket on the upper chest or arm. It consists of a titanium or plastic reservoir covered with a self-sealing silicone septum. You access the port by using a special non-coring needle with a deflected tip. This prevents damage to the septum that could make the port useless, figure 16.20b. Drugs are placed in the reservoir either by a direct injection or through injection into an established IV line. The reservoir then slowly releases the medicine into the bloodstream. Implanted ports are good for long-term therapy and have a low risk for infection. The hidden port offers the patient cosmetic advantages and overall has less maintenance than other types of CVADs. Monitor accessed ports for infiltration that can occur if the needle is not in place or dislodges. Midline catheters. Midline catheters technically are peripheral catheters because they do not enter a central vein. However, their use and care are similar to a PICC. A specially trained nurse can insert a midline catheter. A catheter can be from 3 to 8 inches long and have a single or double lumen. They are inserted in the antecubital area through either the basilic or cephalic vein, often under ultrasound guidance. The basilic vein is best since it has a large diameter. The tip rests right below the axilla, staying below the shoulder joint to reduce the risk from vein irritation from moving the shoulder. These lines can stay in place for up to 4 weeks. Complications. CVADs always have a potential for complications. Careful monitoring and assessment will help you identify potential complications early. Table 16.9 lists common complications, potential causes, manifestations, and interventions. Nursing management. Central venous access devices. Nursing management of CVADs includes assessment, dressing changes and cleansing, injection cap changes, and maintenance of catheter patency. The exact frequency and procedures for these requirements vary by type of CVAD and facility, so it is important to follow your facility's policies and procedures. The following section discusses some general guidelines. Catheter and insertion site assessment includes inspecting the site for redness, edema, warmth, drainage, tenderness, or pain. Observing the catheter for misplacement or slippage is important. Perform a comprehensive pain assessment, particularly noting any reports of chest or neck discomfort, arm pain, or pain at the insertion site. Do not use a newly placed CVAD until the tip position is verified with a chest X-ray. Before manipulating a catheter for any reason, perform hand hygiene. Perform dressing changes and cleanse the catheter insertion site using strict sterile technique. Typical dressings include transparent, semi-permeable dressings or gauze and tape. If the site is bleeding, a gauze dressing may be preferable. Otherwise, transparent dressings are best. They allow observation of the site without having to remove the dressing. Transparent dressings may be left in place for up to 1 week. Change any dressing at once if it becomes damp, loose, or soiled. Cleanse the skin around the catheter insertion site according to facility policy. A chlorhexidine-based preparation is the cleansing agent of choice. Its effects last longer than either povidone iodine or alcohol, offering improved killing of bacteria. When using chlorhexidine, cleansing the skin with friction is critical to preventing infection. When applying a new dressing, allow the area to air dry completely. Secure the lumen ports to the skin above the dressing site. Document the date and time of the dressing change and initial the dressing. Disinfect catheter hubs, needleless connectors, and injection ports before accessing the catheter. Use an alcoholic chlorhexidine preparation, 70% alcohol, or povidone iodine. Change injection caps at regular intervals according to facility policy or if they have damage from excess punctures. Use strict sterile technique. Teach the patient to turn the head to the opposite side of the insertion site during cap change. If you cannot clamp the catheter, have the patient lie flat in bed and perform the Valsalva maneuver whenever the catheter is open to air to prevent an air embolism. Flushing is one of the most effective ways to maintain catheter patency. It also keeps incompatible drugs or fluids from mixing. Use a normal saline solution in a syringe that has a barrel capacity of 10 milliliters or more to avoid excess pressure on the catheter. If you feel resistance, do not apply force. This could result in a ruptured catheter or create an embolism if a thrombus is present. Because of the risk for contamination and infection, use solution from pre-filled syringes rather than multiple dose vials when flushing catheters. If you are not using a positive pressure valve cap, clamp any unused lines after flushing. Use the push-pause technique when flushing all catheters. Push-pause creates turbulence within the catheter lumen, promoting the removal of debris that adheres to the catheter lumen and decreasing the chance of occlusion. This technique involves injecting saline with a rapid alternating push-pause motion, instilling 1 to 2 milliliters with each push of the syringe plunger. If you are using a negative pressure cap or neutral pressure cap, clamp the catheter while maintaining positive pressure while instilling the last 1 milliliter of saline. This prevents reflux of blood back into the catheter. If a positive pressure valve cap is present, it works to prevent the reflux of blood and resultant catheter lumen occlusion. Remove the syringe before clamping the catheter to allow the positive pressure valve to work correctly. CVAD removal. Removing a CVAD is done according to agency policy and the nurse's scope of practice. In many agencies, nurses with demonstrated competency can remove PICCs and non-tunneled central venous catheters. The procedure involves removing any sutures and then gently withdrawing the catheter. have the patient perform the Valsalva maneuver as the last 5 to 10 centimeters of the catheter is withdrawn. Immediately apply pressure to the site with sterile gauze to prevent air from entering and to control bleeding. Inspect the catheter tip to determine that it is intact. After bleeding has stopped, apply an antiseptic ointment and sterile dressing to the site.